welcome everyone on this webinar held from the UK chapter from Pakistan Cardiac Society. This is the first webinar from the UK chapter. As everybody knows that we have established a new chapter in the UK, and I'm the coordinator from the UK based. So it is my honor to introduce to Dr. Uzair Khan. He's a consultant cardiologist in adult congenital heart disease. He's based in London and Westminster and Chelsea Hospital and Royal Brompton Hospital. So I just want to give a brief introduction to Dr. Uzair Khan, that he did his graduation from St. Medical College, and then he moved to the UK, where he has been in a training program, and he has completed, his training deanery was in London, and he has completed specialized in adult congenital heart disease. Since then, he has been working in different hospitals. He worked before in different hospitals, including the Royal Pepford Hospital in Cambridge. Then he moved to the Chelsea and Westminster Hospital, and he's an honorary consultant cardiologist in Royal Brompton Hospital. And we have today our panelist, Dr. Daud Khan. I'm very thankful for him that he's joining from us. He based in the Sheikh Khalifa Medical City in Abu Dhabi, United Arab Emirates, where he's consultant and director of the catheter intervention there. And now currently he is out of the country. He's in the Tbilisi. I'm very thankful he's joining from there. And we have now our other panelist, Professor Dr. Ijaz Hussain. He's the head of department in PIC Peshawar. And it is my honor that he's with me, that Dr. Ijaz, we have done together training in National Institute of Cardiovascular Disease. He was doing training in pediatric cardiology, and I was doing the adult cardiology. And then we have a panelist, our Dr. Ajman Shok. He's a consultant pediatric and adult congenital heart disease cardiologist at Indus Hospital, Karachi. And Dr. Sadia Ilyas, assistant professor and head of department Peds Cardiology MTI, Lady Leading Hospital, Peshawar. And we have Professor Dr. Asif Rahman, head of department PIC Lahore. So I think I'm very thankful for all panelists, and especially Dr. Uzair Khan. He has prepared a very good presentations to deliver a talk for our cardiologists. So, Dr. Uzair Khan, floor is for you now.
Okay, thank you very much for the kind introduction. So I'm just going to talk about challenges in congenital heart disease today and the management based on ESC guidelines. This is a very big topic, and I think this is the first of the series, so I wasn't sure how to what level to pitch this talk at. So I've just kept it at a medium level, so it's relevant for both junior trainees and more senior clinicians. And again, these talk is mainly based on, and the slides are taken from ESC website, so you can access these slides from there as well. So let's quickly talk about some background about the congenital heart disease. So around 40,000 children are born each year with congenital heart disease, according to USA data. And there are similar numbers in the UK. About 4 per 1,000 adults are born, have congenital heart disease. And similarly, when I was looking through some data online, I think in Pakistan, about 3 to 4 per 100 children born do have congenital heart disease. So it's not very uncommon. And out of those population, about 10% fall into complex congenital heart disease. And due to the advancements in the operative techniques and the care that is being provided during the childhood now, most of these children are surviving into adulthood. And in most of the cases, we do not have any cause. They're mostly spontaneous mutations and changes. However, there are some factors that put people or the children at a high risk of congenital heart disease, such as maternal age. For example, if the mother is more than 40 years of age, the chances of Down syndrome and similar congenital heart disease is a bit more common and prevalent. Same goes with diabetes and infections during pregnancy, such as rubella, flu. Um, in Western countries, alcohol and smoking is one of the factors where women do tend to smoke and consume alcohol. Um, Medicines wise, benzodiazepine, retinoid, etc., are also found to be causative in mothers consuming these during pregnancy. And again, some organic solvents such as paints, nail polishes, and glues also carry elements and solvents which can cause problems during the development of the baby. So, as we all know, congenital heart disease is a lifelong chronic condition. It's not um, something that we can take lightly. It starts from a very young age. Children are aware of their conditions and limitations from very earlier on in their life, and that in turn put physical as well as psychological effects on these children. They require repeated hospital admissions, sometimes emergency hospital admissions, and and the kids who go undergo surgery during childhood are exposed to lifelong risks of infections such as endocarditis, arrhythmias, and sudden cardiac death. I mean, as the talk states that we need to talk about challenges, it's a big topic. I'm just trying to touch base on just a few salient points. So if you're talking about psychological effects, the children with congenital heart disease are 5 times more likely to develop anxiety-related symptoms during their childhood and teenage years. And similarly, it affects in their adult life as well. So nowadays, the most recent guidelines suggest proper psychological assessment of all these children when they reach teenage years or in adult life to provide good psychological support. And this has been a challenge even in the Western world and developed countries to find a good psychologist who understands congenital heart disease, and they can counsel children and adults with congenital heart disease. Again, although in Western world there are we think that there are services are equally provided, but that's not the case. We do have areas in even in the developed countries where some areas are more privileged than the others in terms of receiving services um, for specialist services such as congenital heart disease specialist. And in some areas which are more developed, they can get community-based services as well. Again, when the emphasis nowadays is paid quite extensively on transition. So when the kids transition from pediatrics to adult services, then in the UK we have specialist transition clinics where the physicians or the pediatrician and the adult cardiologists will see that child together. So they are familiar with their existing team, and then they know next year when their next follow-up is due, which team will look after them, and what the pros and cons and what processes and access to the services look like. They were also seen at the same time by a specialist congenital heart disease nurse who will counsel these teenagers about the potentials and the differences between the adult consultations and the pediatric consultations. If this is not done properly, we see that a lot of these children get lost to follow up, and they only come to medical attention once they are in a crisis, which will in turn impact their long-term outcome. We have numerous studies in the UK, especially in Royal Brompton, where They have conducted studies which have shown us that uh, patients who or the children who get lost to follow up have poor outcome, irrespective of the complexity of the congenital heart disease. And nowadays, we need to recognize these conditions and their psychological and physiological impacts, and we have to cater for individual needs as per individual, rather than there is no one size fit all in this scenario. Again, these things will have an impact on the memory. They can have a problem with communicating with others or comprehending information given to them, and poor planning abilities. So all these things will in turn frustrate this young individual to feel that they can feel similar or normal as compared to their other siblings and friends. I've just there could be lots of complications, but I'm going to touch base on these ones quickly in my subsequent slides. So because the time is short, so I'm going to touch base on these conditions and what the recent ESC guidelines are in terms of managing these conditions. So the ESC guidelines are based mainly, they classify into three categories: class 1, class 2, and class 3 recommendations, which means that the class 1 is recommended or indicated recommendation. Class 2 is divided into two subclasses, 2A and 2B. 2A means that should be considered, and 2B means may be considered, because class 2 falls into conflicting evidence where there's divergence of opinion. And the class 3 recommendation is where we agree as a whole that this treatment or procedure is not recommended. And again, the level of evidence falls. Level A is when we have multiple randomized controlled trials are backing this data. And level B is when it is derived from a single randomized controlled trial. And the level C is when the consensus of opinion or expert opinion or a center-based opinion or experience is used to recommend that recommendation. So you will see in the subsequent slide that they will be categorized along with these recommendation evidence. First of all, just to quickly touch base on pulmonary hypertension, the cutoff has now reduced from 25 to 20 millimeters of mercury, and the precapillary is defined as PVR less than PVR greater than 3 Wood units, and pulmonary artery wedge pressure less than 15. And isolated postcapillary has been defined as, I think this hasn't changed from the previous guidelines, with the PVR of less than 3 Wood units and pulmonary wedge pressure of greater than 15. Now, the things that are new in the most recent guidelines, which are 2020 ESC guidelines, it is recommended that all women with pre-capillary pulmonary hypertension are counseled against pregnancy. So the risk with capillary hypertension, pulmonary hypertension is much more than post capillary pulmonary hypertension. So in low risk, then it is recommended that all these patients are assessed if there's any doubt whether there's a pre or post capillary component. Invasive hemodynamic assessment is recommended. In low to intermediate risk patients, there's initial oral combination therapy or sequential therapy is recommended in high risk patients, including parenteral. In high risk patients should be treated initially with combination therapy, and then they can have parenteral prostanoids as well if indicated. And in patients with, so this is a revised indication, and if you can see on the right-hand side, the class of recommendation and level of evidence is mentioned in all these recommendations. So you can see what level of evidence is behind this particular recommendation. In patients with Eisenmenger syndrome with a reduced exercise capacity, which they describe as 6-minute walk test of less than 450 meters, there is a suggestion of initial endothelin receptor antagonist therapy followed by combination therapy if the patient fails to improve in symptoms. Now, in terms of shunt lesions, so we describe shunt lesions into pre-tricuspid and post-tricuspid shunt, and the indication of closure is mainly based on the hemodynamic data and whether to do complete or partial closure. And the PVR threshold also differs in both pre and post-tricuspid shunts, and shunt size. The usual recommendation is QPQS of greater than 1.5 should be considered for closure as long as it meets the other criterias. Similarly, desaturation with exercise, filling pressures, and response to therapy are also a major determinant in decision making whether to close the shunt or not. So in patients with shunt lesions, for example, with patients with either ASD, VSD, or PDA, the shunt lesion and non-invasive signs of pulmonary hypertension should have, if there's any doubt that the pulmonary pressures are elevated, or if we see signs of pulmonary arterial elevated pulmonary arterial pressures on the non-invasive measurements such as echocardiogram, then invasive measurement of PVR is mandatory. So the adjusted recommendations currently for closure, as I mentioned, is more than 1.5, QPQS of more than 1.5. In patients who have PVR of less than 3 Wood units, there's a class 1 indication for closure in ASD, VSD, and PDAs. And in patients with a PVR of between 3 and 5, there's a class 2A indication. And in patients with a PVR of greater than 5 Wood units, but if this PVR reduces after PH therapy, then this is class 2B indication for fenestrated closure, that it could be considered, but it's not a strong evidence about it. And again, with patients with a PVR of greater than 5 Wood units, despite optimal therapy, this is advised against closure even for ASD. So there's a class 3 recommendation is that if you close, the closure is not recommended in this patient cohort. Now, with atrial septal defects, the way you assess a patient is whether there's RV volume overload or not. If there's RV volume, the answer is yes. Then you look for PVR. If the PVR is greater than 3 Wood units, then you need to decide whether it's between 3 and 5 or more than 5. The second question you need to ask is, what is the QPQS? If it's more than 1.5 or less than 1.5. If it's more than 1.5 and PVR is less than 5 Wood units, then the closure can be considered. Similarly, if there is there is no RV volume overload, and the risk of paradoxical embolism is low, then closure is not recommended. Similarly, if the risk of paradoxical embolism is high, then the closure is recommended, and the class of evidence is 2A. If you have patients who has PVR of more than 3 Wood units, then you need to see if they have LV disease or not. If they have no LV disease, PVR, the ASD closure is not indicated. If there is an evidence of LV disease, then the recommendation are for balloon testing. And then you need to weigh benefits against the risks, whether if you close the ASD, then would you make the LV disease worse by increasing the LV overload. Now, if the patients with a PVR of less than 5 Wood units and the QPQS is more than 1.5, the next question is that if the PVR falls with PH therapy, if the PVR falls below 5 Wood units with therapy, then the fenestrated closure could be considered, but it's not indicated. It's a class of evidence is 2B. And if the PVR does not fall, again, the closure is not recommended. So VST is something similar. Sorry, I'm just going whiz through in the interest of time, and there's lots to cover. So I'll be happy to answer any questions in the end. So again, with the VST, similar question we need to ask if the if the LV is overloaded or not. If the answer is no, then you need to see if there's any prolapse of aortic valve causing aortic regurgitation. If there is, then the closure could be considered. If there is no aortic regurgitation, and if there is no history of endocarditis, the closure is not recommended. If there is a history of endocarditis, then closure can be considered. Similarly, when the pulmonary arterial hypertension, if the PVR is more than 3 Wood units, and but less than 5 Wood units, and QPQS is more than 1.5 Wood unit, then closure could be considered. Again, the the thing goes as with ASDs. If the PVR does not drop below 5 Wood units after therapy, then closure is not recommended. So now quickly talking about AVST, atrioventricular septal defects. If the patients have Eisenmenger physiology and PVR is greater than 5 Wood units, then the surgical repair is not recommended, especially patients who present with desaturation on exercise. And for the partial AVST, if there is a significant RV volume overload, then the surgical closure is recommended. But again, in this setting, the surgery should be performed by a congenital cardiac surgeon rather than any cardiac surgeon. In terms of valve regurgitation in patients with AVST, there is if the patient is asymptomatic, if the patient is symptomatic with moderate to severe valve regurgitation, AV valve regurgitation, then the surgery is indicated. On the other hand, if the patient is asymptomatic and they have severe left-sided AV valve regurgitation, and the LV end diastolic volume is more than 45 millimeters, or LV ejection fraction is less than 60%, and the other causes of LV dysfunction have been ruled out, such as coronary disease, etc., then this can be the patient the surgery is then indicated in that scenario. In asymptomatic patients with severe LV valve regurgitation with LV EDF if it's less than 45 millimeters and the EF is more than 60%, and if there is a high likelihood of successful repair and low surgical risk, then the surgery should be considered, and the level of evidence is 2A. Now, in terms of PDA, so again, we see, as with VSTs and AVST, we see if there's LV volume overload. Recommendations are almost similar in this condition as well with the PVR. If it's between 3 and 5, you treat with therapy. If it comes down, and consider closure, evidence is 2B. If it doesn't come down, then the closure is not recommended. Now, in terms of LV outflow tract obstruction, the way when we decide about intervention, the LV outflow tract obstruction could be either subaortic, valvular aortic, or supraortic stenosis. So we need to see what the level of obstruction is. If the patient is symptomatic, then the intervention should be considered. If the patient is asymptomatic and the LV ejection fraction is less than 50%, and the intervention is indicated in that scenario. But in patients who have LV ejection fraction of less than 50%, if it's like LV ejection of more than 50%, and they claim to be asymptomatic, then we do exercise testing and see if that unmasks their symptoms. So either they become symptomatic. If they become symptomatic, symptoms may include breathlessness, dizziness, angina. Those symptoms, then the intervention is recommended. If they do not, exercise does not unmask the symptoms, however, there's a blood pressure drop during exercise, then there's a class 2 indication for intervention in this scenario. And if the blood pressure does not drop down and the repeat follow-up is recommended, and as long as the surgical risk is low, then the indication may be considered, but again, the evidence is not that strong. So in the valvular aortic stenosis, the patients, these are the revised recommendations as compared to 2015 guidelines. So intervention is recommended in all symptomatic patients who have a mean gradient of more than 40 millimeters of mercury. Intervention is indicated in patients who have low flow, low gradient AS, where the LV ejection fraction is impaired. However, there is contractile reserve, then intervention is indicated. This can be unmasked, checked by doing dubitamin stress echoes, etc., or any form of stress modality. In patients who has severe aortic stenosis and they have abnormal exercise test, then they would need to have um, there's an indication for closure. But again, you have to be extremely careful in exercising patients with severe aortic stenosis, which is usually not recommended. But if you have intermediate probability of severe AS, then controlled exercise or low dose dibutamin stress echo can be used to evaluate the severity of aortic stenosis and to assess the contractile reserve. And any patients who are asymptomatic, however, the LV function is less than 50% and no other causes are found, then the intervention is recommended to make sure that you intervene before the LV function deteriorates further. And again, with asymptomatic patients with severe aortic stenosis, if there's a drop in blood pressure and with exercise, there's a 2A indication. And if the patients are asymptomatic and if they have either very severe AS, which is defined as Vmax of more than 5.5 meters per second, or severe valve calcification, and or the rate of progression of the velocity or Vmax is more than 0.3 meters per second per year, or if they have markedly 3 times the baseline of BNP levels, or if they are developing signs of pulmonary hypertension, then although they are asymptomatic, but the intervention should be considered in these scenarios. So the other thing that is recommended is that if they have any other concomitant problem, then the surgery should be considered. For example, if someone is going surgery for severe aortic stenosis, and if they have either dilated ascending aorta or if they have any coronary disease, then all these things could be done in one setting. Again, with patients with moderate stenosis undergoing bypass surgery or ascending aortic surgery, then the consideration for intervention can be, there's a conflicting evidence and divergence of opinion in this scenario, but that could be considered. And again, with supravalvular aortic stenosis, there is, if the gradient is more than 40 millimeters of mercury, surgery is recommended in symptomatic patients and patients with either asymptomatic patients with less than 40% with symptoms attributable to obstructive symptoms, LV dysfunction less than 50%. And if the surgery is required for coronary disease or other valve problems, then the surgery is indicated in this scenario. In subaortic stenosis, again, something the guidelines are more or less similar. The mean gradient is of less than 40 is being uniform in all the recommendations. And patients with severe AR with LV and diastolic dimensions of more than 50 millimeters of mercury or 25 millimeter per meter square body surface area, or if the LV ejection fraction is less than 50%, the class of recommendation is 2A. Coarctation and recoarctation, we need to see in these patients, we need to see if they have arterial hypertension. If the answer is yes, we need to see what is the peak to peak gradient difference. If it's more than 20 millimeters of mercury, and this is invasively confirmed difference, not non-invasive measurements, then the intervention is indicated. If there is more than 50, if the peak to peak gradient is more than 20 millimeters of mercury, however, if it's less than 20 millimeters of mercury and the narrowing is more than 50%, then the intervention can be considered. However, if there's peak to peak gradient is less than 20 and no narrowing more than 50%, then the conservative treatment is recommended. I think I'm going to skip this slide. I'm going to talk about the Marfan syndrome and any heritable thoracic aortic disease. So aortic valve repair is in patients who have Marfan's or any hereditary or connective tissue related thoracic disease. The surgery is recommended. The level of evidence is class 1. However, this should be performed by an experienced surgeon. In patients with Marfan syndrome who have aortic sinus diameter of more than 50 millimeters of mercury, then the surgery is considered. However, there is a caveat that sometimes the patient, if they are at the extreme ends of the body surface area, either they are too tall or too big, or they are too short or too small, then those the diameter measurements could be tailored based on the individual in front of you. And patients with Marfan syndrome with the aortic diameter of more than 45 millimeters of mercury and additional risk factors. The additional risk factors could be such as any family history of spontaneous dissection, progressive aortic regurgitation, or if the patient wants to have to start the family, if it's a female patient, if they have got uncontrolled blood pressure, or if the aortic size has increased 3 millimeters per year, then the surgery can be considered. And patients who have TG, FBR1 or 2 mutation, including Lloyd-Steed syndrome, who have aortic sinus dimension of more than 45 millimeters of mercury, the surgery could be considered. Again, with patients with bicuspid aortic valve with the aortic size or sinus size of more than 50 millimeters of mercury with additional risk factors, or if they have coarctation, then the surgery could be considered. And bicuspid aortic valve, anyone with aortic dimensions of more than 55 millimeters of mercury, the surgery is recommended. And again, with Turner syndrome, we base the size based on because the patients are short. The recommendation are that the aortic size should be measured indexed to the body surface area, which is the cutoff is 25 millimeters per meter square. And if they have any associated risk factors for dissection, such as bicuspid aortic valve, elongated transverse aortic arch, coarctation of aorta, or uncontrolled hypertension. Elective surgery for aneurysm of aortic roots and ascending aorta, again, in patients with Turner syndrome who are more than 16 years of age, and they have not associated risk factors, then the surgery can be considered, but the level of evidence is 2B. Again, RVOT guidelines for RVOT interventions are based on the peak gradients, more than 64 millimeters of mercury. If the gradient is less than 64 millimeters of mercury, however, they have symptoms related to RVOTO or RV dysfunction or left to right shunt, including ASDs or VSD, then there is no follow-up is needed. But if any of these symptoms are positive, then the intervention is indicated. I think I'm going to skip this slide. I'm going to quickly talk about the tetralogy of Fellow, where there is the recommendation of repair is in patients with no native outflow tract obstruction. Catheter is preferred if anatomically suitable. And I'm just going to talk, in the interest of time, I'm going to talk about just the salient points in this recommendation is that if there's a progressive RV dilation to more than 80 ml per meter square, or RV and diastolic volume index is greater than 160 millimeters of square, then pulmonary valve replacement should be considered in asymptomatic patients or with severe PR. Okay, I'm going to skip in the interest of slide. And so now this slide shows that if in patients with tetralogy of Fallot, if there is a slow anatomical isthmus, and then before you do the closure, we need to find a substrate for VT, because these patients are prone to develop ventricular arrhythmias, and risk stratification and preventive ablation can be considered in tetralogy of Fallot patients. Again, ICD can be considered if the QRS duration is more than 180 milliseconds, and patients have either non-sustained or symptomatic VT, or inducible VT at EP studies, then the ICD should be considered. Okay, just quickly talking, I'm going to talk about TGA and the long-term transposition of gate arteries. The patients who undergo atrial switch operation, in patients with severe systemic AV valve, which is tricuspid valve, if there is significant systolic, without significant systolic dysfunction, which is classed as more than 40%, valve repair or replacement should be considered regardless of symptoms, because the idea is that we need to intervene before the LV is non-repairable, because the systemic right ventricle is, as we know, is not developed to sustain systemic circulation in the present, especially if they develop overload with valve regurgitation. And again, with patients with post-arterial switch who are asymptomatic, with baffle leaks, and they develop substantial volume overload due to left to right shunt, covered stents or device closure should be considered when technically feasible. So this is again class 2A recommendation in this scenario. In patients with baffle leak, if the patients require a pacemaker or ICD, the closure of baffle leak with a covered stent should be considered when technically feasible prior to insertion of transvenous leads. And again, in patients who are asymptomatic but do have baffle leak, stenting may be considered when technically feasible. Again, the level of evidence is conflicting, and there's a divergence of opinions here as well. So this is a Swedish study where it shows that a lot of patients with arterial switch operation have shunt lesions, or sorry, the baffle leaks. More than 50% have baffle leaks in that study. And patients who undergo arterial switch, so if the aortic root dimension is more than 55 millimeters of mercury, for more than 55 millimeters, in normal size adults, then for neo-aortic valve replacement for severe aortic regurgitation, then you need to the surgery could be considered, but again, the level of evidence is 2A. And the slight change in that scenario is that the stenting should be considered for the branch pulmonary artery stenosis, regardless of symptoms, if the diameter is more than 50%, and the RVSP is more than 50 millimeters of mercury. TG and Rastelli type repair, in symptomatic patients, RVSP of greater than 60, with or without severe PR, should undergo intervention. Preferably, the recommendation, the change is that the catheter intervention is preferred to surgical intervention in this scenario. In patients who are asymptomatic with severe RVOTO or severe pulmonary regurgitation, catheter intervention can be considered if they have reduced exercise capacity, if RV and systolic volume index is more than 80 ml per meter square, or if there's progressive RV dilation, or if RVSP is more than 80 millimeters of mercury. Although they are asymptomatic, then the surgery could be considered. The level of evidence is 2A. In CCTGA, again, the recommendations are more or less similar, with LVEF should be more than 50%. And again, here, instead of repair, tricuspid valve replacement is indicated rather than repair, because the repair is not found to be very successful in this patient cohort. And again, biventricular pacing should be considered in case of complete AV block, which is common in these patients. And if the LV function is, if there is ventricular pacing requirement is more than 40%. In symptomatic patients with severe tricuspid regurgitation and the LVF is less than 40%, then the replacement may be considered. But again, the level of evidence here is 2B. This is in conclusion with for the TGA, the tricuspid valve repair or replacement after muscular stenting, or tricuspid valve replacement only in CCTGA. Again, it needs to be considered before the RV has worsened even more. So the EF should be more than 40%. And Befelic is more common, as we know, more than 50% on the Swedish study. And we should look actively for Befelic before pacemaker insertion, and closure of Befelic percutaneously is feasible. When pacing is necessary in CCTGA, biventricular pacing is recommended, and the level of evidence is 2A. Just last couple of slides on univentricular hearts, and the patients is recommended that unoperated or palliative patients with univentricular heart should be assessed in specialized center, and they should undergo multi-modality imaging, including echo-based, MRI, and CT-based, to make proper assessment, along with hemodynamic and exercise data. Only well-selected symptomatic cyanotic patients with low pulmonary vascular resistance should be considered for Fontan circulation. So pulmonary resistance for Fontan circulation, pulmonary resistance must be low for it to be successful, because there's a passive flow into the lungs. So patients who have severe cyanosis and decreased pulmonary blood flow, but the PVR or the pulmonary pressures are low, they could be considered for bidirectional Glenn. Patients with severe cyanosis and decreased pulmonary blood flow, which are not suitable for Glenn, they can be considered for systemic to PA shunt. Again, the last thing is the heart transplantation or heart and lung transplantation can be considered if there is no conventional or surgical option, and the patient is otherwise well. And the last slide, I think, regarding sustained arrhythmias with rapid AV conduction should be treated promptly in patients with Fontan circulation, because they can deteriorate very, very quickly. So anyone who comes in with sustained atrial arrhythmias, they should be treated as an emergency, because all their circulation is based on passive, and then any arrhythmia can tip them over in terms of hemodynamic stability. If there is an atrial thrombus or atrial arrhythmia or any thromboembolic events in Fontan patients, the anticoagulation is considered, and it's recommended as class 1 recommendation. And the patients who have Fontan circulation, and especially women, are advised against pregnancy. Although in the center I've worked in before, we do have 1 or 2 patients who do get pregnant with Fontan circulation, but the outcome is not very good, and there are associated miscarriages, especially with oxygen saturations less than 85%. Okay, so I think we're running out of time. So I think this is the last slide. In patients with arrhythmia, proactive approach, EP studies and ablation should be considered in Fontan patients. And the main emphasis nowadays in Fontan patients is regular liver imaging, because these patients are prone to develop hepatocellular carcinomas, and they can end up with triple organ failure, including heart, lung, and liver, and which are again deemed unsuitable for transplant. In selected patients with significant cyanosis, device closure or fenestration can be considered, but it requires careful evaluation in a specialist center, and all the decisions in these settings are based on multidisciplinary meetings which are held regularly in tertiary centers. So this is a slide showing this information that I've presented today has all come from 2020 SE guidelines for congenital heart disease. Thank you very much. I'm sorry, I think I might have run over a bit.
Thank you very much, Dr. Uzair Khan. And it's really quite difficult for you to wrap up the things in one presentation within 40 minutes, but I'm really thankful. It was really very brief and descriptive presentations, which you cover almost all topics. Everybody knows that adult congenital disease topics are quite large, vast medical issues, then we can't cover everything in one presentations. So really, thank you very much for that. And I would like to request my panelists now and audience to ask any questions, then we can answer and discuss on these things, and then we can close the session. Anyone from the audience, please. And I will request to all my panelists, please, if it is possible for you to switch on the cameras so our audience can have an interaction with us as well, if possible for all of you.
I don't know how to on my camera.
That's fine. Okay. Thank you very much. Okay. Ahsan, thank you, Dr. Sadia. Thank you, Dr. Arjman and Dr. Ejaz. I think Dr. Daud Khan have some issue with the camera. So Ahsan is our supportive team member. Is there any question from audience?
Sir, the audience can write the question in the question answer section at the bottom.
Okay.
So you can just read it there.
Yeah, I can. Yeah, fine. So I'm trying to see the question.
Yeah.
In the chat box, am I right?
Yes, sir. In the chat box or the question answer, there is another chat box right next to the chat.
Okay.
Q&A. Yeah. So they can write the question here, or either they can raise the hand and we can allow them to talk.
Fine. So
Hello.
from audience,
Hello.
anyone can? Yes.
Can you hear me?
So, yes, Dr. Daud Khan, we can hear you.
Let's the audience. If somebody want to ask the question, let's give them the preference first.
Yes, definitely. So there's nothing, no question I can see from the audience. So
Stunned silence.
yes. No, that's fine. I think I can ask one question. I can initiate this discussion, might be then our panelists can answer. So it's question from the panelists as well. So some of patients, as we know that the PFO or ASD, PFO is most, is around 25 to 30% of population, they have a PFO. And especially with a female, they want to become a pregnant. And we know that some of patients like cryptogenic emboli is common in PFO patients sometime. So is there any, I would say, advice to be given to the pregnant lady, those who have a PFO, regarding DVT prophylaxis for during the pregnancy time?
Yeah, I think they should have usual precaution and as with any patients who with PFO who undergo pregnancy. I think the evidence is conflicting. So I think what we usually tend to say is that if patients who don't have any history of any events such as TIAs or any thromboembolic complications as a result of that, then I think what we tend to do is to give them aspirin during pregnancy to minimize that risk. but obviously the anticoagulation is not recommended as a routine in pregnancy due to congenital effects and maternal and fetal effects. So it's the decision we usually based is individual case-by-case patients. So we see these patients who have congenital heart disease in joint obstetric and cardiology clinics. So where the obstetrician assesses them from their perspective, and the cardiologist, we will look through with our point of view. We need to make sure there's no underlying arrhythmias, what kind of what type of PFO it is, if it's a big PFO or as a small PFO, any previous risk factors. I think previously PFO closure was indicated patients with migraines, etc. But again, that wasn't completely successful in all cases. So I think in pregnant patients who are pregnant, you have to make the decision case by case.
That's great. I would like to ask from my Pakistani panelists and from Dr. Dawood from overseas. So what's your practice in Pakistan? Anyone from panelists, please? Dr. Arjman, your mic is mute. Your mic is mute.
Okay, I think who is going to answer? Is that Dawood is going to answer, or should I answer?
Yeah, please go ahead. We can ask Dr. Dawood as well.
I think Dr. Uzair explained very nicely. I think it's a sort of, when it comes to ACHD, I was just thinking when I was listening to the lecture as well, one is in the developing countries, one is in the developed countries, and both aspects of the sort of, ACHD is a different phenomena. It's a little bit different way of management. It's a little bit different way of looking after it as well, because in developed countries, if you look at it as well, there is a system, there is a specialties, there are extra cardiac manifestation, there are management, there are counselors, there are liaison nurses, there are transition clinic, there is a lot of things going on. But if you look at in the developing countries, when I go to Pakistan, when I'm sitting in my village, a lot of people, they refer patient. I see some adult as well with mitral valve problem, with tetralogy of Fallot, with VSDs, ASDs, children, adult. And if you look at there, so I'm become a bit confused. And that's why I left the country as well in 2014, 2004. I thought, I don't know from where to start. And the question here is, for this sort of patient, if you look at in the developed countries, yes, as Uzair mentioned, you look at the previous history, you look at the genetic factor, you look at the fame, all sorts of things, and then you can think about individually that you can start the aspirin or whatever you can give the people. But if you look at in the developing countries, there will be a lot of sort of patient, who had P4, who had 15, 20 pregnancies without any precaution, without anything. So I think here it's a very case by case, and the way you manage and where you are sitting and how you can prevent complication. I don't think I will give aspirin to each and every woman who had a P4 because there is no studies, and I don't think it's a very sort of safe practice as well.
That's great. Dr. Arjman, you would like to say something, or Dr. Ejaz, or Dr. Sadia?
Yes, just focusing on the PFO in the pregnancy. I don't think, obviously in the past, the people used to close the PFOs with a very, little indications, and then there were studies, actually, no one actually shown any benefits. So just with no history of anything previous, like AIA, I don't think there's any indication for closing those PFOs.
Absolutely, absolutely.
I think it's like a lot of people nowadays, when they travel by flight, they say, when my wife say, can I have an aspirin as well? I say, why do you want to take aspirin? He say, oh yeah, blood clot and this and that. So this is like one of those sort of things, if you throw into the community, some people will be just using things, without any evidence.
Actually, the basic advice, Wahid, is that usually the deliveries, they should be in a proper hospital, and the fluid, we advise them that need to be very careful with the bubble-free IV fluids if this is required during treatment or during delivery. So usually we give that advice, of course, that there need to be and regarding the exercise and all these. But closure, we really don't recommend, and also aspirin, routinely don't advise.
I would like to add, PFO actually comes very down the list. As Dr. Daud pointed out, we are facing a lot of other structural problems with more difficult and challenging sequelae like VSDs. We are facing a lot of pregnancies with Eisenmenger. We are facing a lot of pregnancies with ASDs. So I guess PFO comes a little down on at least my list of worry when I'm seeing all these pregnant ladies in the clinic.
Yeah, that's really great, because the reason I asked this question is really very rare, but it's very tricky. I come across with one of my clinics, Gynae clinic. I was seeing one patient, she was incidentally found to have a PFO, and this was her second pregnancy. So as everybody knows, you all have known that there's no clear-cut guideline to whether we need to give DVT prophylaxis for them or no. So this is just for, as Dr. Uzair mentioned in the slides, for the audience, that we have level of evidence, where the consensus statement for level of evidence there is. So at the end, I come across with the different hospitals, and then we found that the Oxford Hospital here in UK, and they have a consensus statement that any patients who have a PFO, they should have a DVT prophylaxis, low molecular weight heparin during the pregnancy. So that's the one hospital practice, and there were another trust as well. But there's nothing, the rest of other trusts, I'm not pretty sure, but I'm sure that they're not offering any DVT prophylaxis. So that's a consensus statement, honestly. So the conclusion is that is a person, everywhere is different practice, and there's no clear-cut guidelines for any DVT prophylaxis in PFO. That's great. Any comments from the panelists about?
I think my great colleague Ijaz is there, and Professor Arjuman and Sadia and Asif, and all very dearest colleague and teacher in some ways, friends and all sorts of things. I think the important thing is in Pakistan, I think I'll just say with my experience, I think there's a lot of things going on, a lot of patients being managed by the general cardiologist, coronary adult cardiologist. And if you look at your audit as well, nobody explained to the patient, what they had. And even the cardiologist doesn't know as well what sort of advice you should give to the patient, like extra cardiac, lifestyle, psychological, complication, infection, vaccination, what you are going to expect after 2-3 years, what is the echo finding. And most of the echo, if you see, a lot of people do echo, there is no tricuspid regurgitant jet. There is no pulmonary diastolic pressure. The echo reporting is the same format as like a normal coronary doctor. LV in diastole, systole, fraction shortening, and that tabulated form of sort of, unless and until echo is done by the pediatric cardiologist and proper laboratory as well. So I think the awareness, I don't know how to convey to the people as well, that this patient, even if there is no ACHD, a pediatric cardiologist is a well-trained person, for him. A child, an adult is the same as well, to be really honest. There is no need to do highly specialized training as well. I'm myself a pediatric cardiologist, had interest in adult congenital heart disease, So I think this is the big dilemma for me in developing countries, in Pakistan as well, that these patients are completely lost and they just go here and there and nobody gives them the right direction. I think Ijaz can add a little bit more as well, but I'm just speaking in a very blunt and a very straightforward words.
Yes, I think you are right, Dr. Daud. The delay in the referral is usually because some of the people, they are told that their hole would be closed with time. So proper referral is important in terms of early diagnosis and treatment. And then we have now the pediatric cardiology program, which has developed, and we have early diagnosis. That issue is somehow being sorted with time. There is referral from our adult colleagues in time, which we see, as well as from our pediatrician. So probably now the referral, the system is quite improved. We are seeing like early in time the patient with TGA within a week. So the referral issue is somehow I think this is improving. The management part is then like the first switch in Pakistan was in 2004. So we see we have the oldest switch, which was done by Asim, is like and Dr. Jamal they did. So it is now like not yet 20 years old. So we have yet the brunt which Dr. Uzair discussed, the fountain problems, the other related the CHD. So the post-surgical one we will face in the future, and we need to develop a proper program as well. We are working with the College of Physician on developing a adult congenital program with so that then those patients who are already old enough, and we really need the adult input. For example, if a patient with 25 years old, 30 years old, in terms of fluid management, in terms of arrhythmias, we need an EP. We haven't developed the pediatric EP as well, so we need help. The other day we saw one ASD with left-sided pathway, and then we had to refer to the adult. So this needs like collaboration and some centers to get together and develop this field, because we need to develop it, because we now have patients, although not in as much number as in developed countries. So we need to develop it, and we, of course, we would need help of Dawood and the UK colleagues to develop this program.
That's really good. I think, Dr. Ijaz. I think, Dr. Uzair, this collaboration is very important to establish any program with developed countries. So might be Dr. Uzair will be the big assets for Pakistani cardiologist team to establish the program and helping from the UK based. We will discuss later on this. What do you think, Dr. Uzair Khan?
Yeah, definitely. I'm more than happy to help and support development of any services which are ACHD based. In the developing countries or in the developed countries, I think the setup is a bit different, and I think Pakistan has to go a bit long way. Usually, all the interventions in the adult congenital patients are usually done by in the UK at least by the pediatric surgeons. So if they need a surgery in adult life, those surgeries are carried out by pediatric surgeons. And similarly with the electrophysiology EP side of things, or interventions in congenital heart disease are carried out by pediatric cardiologists as opposed to adults, because adults do not have similar background about congenital heart disease as compared to the pediatric congenital cardiologists. So the setup in the UK is that all the cardiac interventions, catheter-based interventions, are carried out by pediatric intervention cardiologists, and similarly surgeries are also done by congenital the pediatric congenital surgeons. And later on, when they approach their 30s and 40s and even 50 years of age, when they develop coronary disease, then we have a setup where the adult non-congenital cardiologists will pair up with a congenital cardiologist to carry out bypass operation, for example, or anything that is not congenital related. So I think there is a system to be set up based on what the setup currently is in Pakistan. So I think if the if pediatric surgeons and interventionists are not happy to operate or do procedures in adults, then I think it will be a difficult thing to achieve quickly, because someone to train from scratch an adult non-congenital person to do congenital surgeries is not going to be very successful, and the outcomes would not be very good. So therefore, in the UK, what they have done is previously we used to have pockets of surgeries, congenital surgeries done all over the country. Now they have centralized all these things into specialist centers. So in London, there are 3 centers now, as opposed to 5 or 6 before, where all the congenital surgeries are done. So again, if you go out of England or out of London, they have concentrated. So there are 5 or 6 centers throughout the UK where the surgeries are performed, so that the volume is more and the outcomes are better, rather than if a surgeon is doing 5 TJs in a year as opposed to 30 TJs in a year, obviously the outcome would be better than someone who's doing more. So I
Uzair,
think we need to
to
centralize
just
the
add to
system.
you that what you said about England is exactly what we are following in Pakistan. The pediatric cardiologists are doing the interventions, and the pediatric cardiac surgeons are the ones dealing with congenital surgeries there. What
They are
Dr.
the same.
was
Okay.
mentioning was the referral system was a bit haphazard, but as far as the interventions are concerned, the adult cardiologists refer them to us as soon as they see the patient. They are there to help us.
All right, okay.
We need help in the coronaries, but they don't. It is
Okay,
us.
no, that's good. But I mean, I wasn't aware of the system, but what I was trying to elucidate was to develop a centralized system. For example, if you have 5 hospitals in Karachi, for example, or in Peshawar, where in all hospitals there are some surgeries are done in small numbers, so I think there's something that we might need to look into is to centralize that process. So if you have a big center where more surgeries are done in one center rather than pockets of surgeries done in different centers. So obviously the outcome will be better in centers where the volume is more. So I think that to improve the outcome and to reduce the morbidity and mortality in these surgeries, I think, because obviously this is not a common condition, so not everyone can have vast experience in surgeries like these. So I think centralized system might be something that we need to look into.
Okay.
Thank you much. I think in the interest of time, we need to wrap up because our audience, they have one question I will ask from panelists, so it would be great. So one of our attendees, they asked question, option for coarctation of aorta with arterial hypertension for repair and medical treatment. So I think that Uzair, you have shown the slide. I think you clearly mentioned about that patients with coarctation of aorta with hypertension, the class 1 indication for repair.
Yeah, so do you want me to come back to that slide?
No, I think anyone from panelists, they can answer if I'm not taking wrong interpretation from your slide. So I think we are going to finish with
coarctation and recoarctation. So let me bring up the slide.
After this discussion, I think we are going to close the session.
Okay, so this is what I showed earlier. So if the patients have arterial hypertension and if the peak-to-peak gradient measured invasively is more than 20 millimeters of mercury, then the intervention is needed. But if the peak-to-peak gradient is not more than 20 millimeters of mercury, however, the narrowing is more than 50% of aorta, then the intervention is indicated and the level of evidence is 2A, which means that there's divergence of opinion, but on balance, they think can be considered like 2A. On the other hand, is that what the question was, or?
I think that's the main of that question, is that in case of coarctation of aorta, option for coarctation of aorta with arterial hypertension for repair and medical treatment.
Yeah, so I mean, if that doesn't fall into that category, then it's a conservative management. If the peak-to-peak gradient is not more than 20 millimeters of mercury and the narrowing of coarctation is not more than 50%, then it's a medical management. The intervention is not indicated.
Thank you much. Thank you. I would like to ask at the end some comments from our panelists, and then I close the session. So I would go first to Dr. Ejaz. He's on top of my list from the screen.
Yeah, it was a nice activity, and I think we hope to continue these activities. And thank you, Dr. Uzair, for a very nice presentation and enlightening us about and this also shows the adult cardiologist interest in pediatric cardiology, because like this shows that because mainly the adult team is what we thought is mainly focused on coronaries and structural, but this is a good thing that this topic has been highlighted and discussed on this forum. And I think you have to, in front of you is written as Dawood Khan. So I think you are Wahid, not Dawoud on the.
Yeah,
Yeah,
I think
so
there's.
so you're Wahid,
Hassan,
not
can you change my name,
Dawoud.
please?
So it was a nice presentation, and I hope we continue this activity in the future, inshallah.
Thank you,
Just
Dr.
to
Ilyas.
mention one thing, that because I had to whiz through because it was a big topic and I wanted to cover lots of things. So we can even talk about one topic for an hour at least easily. So I just
I
tried to
understand.
touch it. It might have gone very quickly, but we can do smaller sessions, concentrating on topic-based discussion as well in the future if need be.
Definitely we take this. But I think I will, Doctor. I think I will take Dr. Dawood. His battery is running down, so might be he want to say something before his battery dead. Dr. Dawood Khan, any comments from your side for this session? I think no. Okay, I'll ask.
Anybody can hear me?
Yeah, I can hear you.
Yes, yeah. Okay, Wahid, thank you so much for organizing and give us the opportunity to see Ijaz, Sadia, Arjuman, Uzair, you, and the rest of our colleagues. I think we need some more meeting like this as well. Good luck, Uzair. And I'm in Tbilisi just with some family business. My battery is running. And have a good day. Jazakallah khair. Remember in dua. Assalamu alaikum wa rahmatullah.
Wa alaikum salam. Thank you, Dr. Dawood. Dr. Sadia Ilyas.
Yes, I'm very happy that this topic came up because this is one of the very most needed and developing specialty in Pakistan. The fact that we are introducing adult congenital, talking about it, and we wish to train people, that would be wonderful. I disagree with what Dr. Dawood said. I think we do need to involve our adult colleagues as well because they do know the dynamics better in adult, and we need a program together with pediatric cardiology so we can develop the structural heart better in adults. And thank you for inviting me.
Thank you, Dr. Sadia. Dr. Arjuman.
Yeah, thank you very much. I mean, thanks for Uzair for giving us a good talk and covering almost everything in just very short time. Now, I mean, there are actually a lot of challenges in Pakistan because, as you know, that I've worked mostly in UK. So in last 4 or 5 years, I've seen a lot of things which actually I wouldn't have done there in UK. And also, we really need to focus on more of subspecialty type practice because everyone wants to do everything. So which is not good. Even at pediatric cardiology level, I think that partly because of the private practice. So if the government give a lot of money to the people who are actually working, then obviously that part of the private practice will go off, and then people will more focus on subspecialty. And then obviously this is going to be a lot of growing need for the ACHD services here, so which needs a multidisciplinary approach. So hopefully we will be able to to develop this specialty in future with all other colleagues involved in this. So thank you very much. Thanks for inviting me.
Thank you very much, everyone. I would say especially thanks to Dr. Uzair Khan, and with short notice he accepted my request, and he spent a lot of time to prepare these presentations, and he delivered on time. And really, I'm very thankful for you, and thankful for all the panelists that they have taken their time from busy schedule to dedicate it with this session for sake of our trainees in Pakistan and worldwide as well. Pakistanis, those who get to benefit from this academic activities. And I'm very glad to say, honestly, today that this is the biggest step from Pakistan Cardiac Society, those who opened the chapter in the UK. From this platform, I believe that in long term, we will make a bridge between the Pakistani cardiologists working in the UK and Pakistan to work together for betterment of our nation, by offering the different services and establishing the services in Pakistan. So that's our whole aim, and inshallah, we will fulfill this one with commitments. Thank you very much, everyone, and bye-bye. Have a rest of the day is good.
Bye,